Hello, everyone, and welcome to today's edition of Patcast. Today is May 7th, 2025, and I'm Rifat Mannan in California. And we are continuing with our dermatopathology lecture series. And today is our seventh lecture in this series. And our guest today is Dr. Dirk Elston, who serves as professor and chair in the Department of Dermatology and Dermatologic Surgery at the Medical University of South Carolina. And he's a very eminent dermatologist and dermatopathologist. And today we also have with us one of our previous speakers, Dr. Hades Skapsky. And I would request Dr. Skapsky to please introduce Dr. Elston to the audience. Thank you, Dr. Skapsky, also for joining us today. Thank you.
Okay, thanks so much for having me back. And it's such a pleasure to introduce you to Dr. Dirk Elston, who is a former mentor and hero of mine. So I met Dr. Elston back when I was a resident. And at that time, I really kind of depended on his amazing video lectures that come with his textbook. He literally wrote the textbook on dermatopathology, a wonderful kind of intro guide that I recommend that all dermatology residents and pathology residents interested in derm paths should read. And Dermatopathology by Dirk Elston. And I had the pleasure of rotating with him at Ackerman Academy as a resident when he was the director there. And now he is chairman of dermatology at MUSC, where he teaches both dermatology and dermatopathology. So without further ado, Dr. Elston, passing it over to you.
Thank you so much. So today's topic is cutaneous infections, something that I have had a long-held interest in, and will move right on. We recently have lived through the years of the infections, where COVID dominated our lives, then respiratory syncytial virus. It just seems to go from one thing to the next. So let's review quickly some of the COVID data. There were lots of things reported with COVID. Perniosis, morbilliform eruptions, retiform purpura, leukocytoclastic vasculitis, all sorts of cutaneous manifestations with skin findings in up to 20% of all patients. And you can see all of the different findings. One that became important early on was this Kawasaki's like presentation in kids. And then urticarial vasculitis as a presenting sign. We normally think of that associated with connective tissue disease, especially lupus erythematosus, but it can be associated with viral diseases as well. And of course, COVID can trigger various autoimmune phenomena after you've had the infection. COVID toes really look a lot like chilblains, which of course can be a finding of lupus erythematosus. And then some of the data have suggested that patients just had lupus or just had other causes of chilblains, wasn't necessarily associated with their COVID. So, this was one of those reports that's suggested all that glitters was not COVID, and that most of the chilblains associated were not really manifestations. And then there were all of these reports of varicella-like eruptions with COVID. Well, they turned out to be chickenpox. So, it's diseases that are common remain common even during a pandemic. The next thing that came along, of course, was monkeypox with fever, headache, fatigue, myalgia, all of those things. The image that you're seeing down at the bottom was sent to me before the monkeypox pandemic was reported. It came to me from a dermatologist in the United Arab Emirates saying, hey, we're seeing patients showing up with these lesions. And We certainly said it's umbilicated. They look like a pox or parapox virus. Um, the UAE and Bahrain are places where U.S. Navy will dock when they deploy, and they are still vaccinated with vaccinia, and they don't get vaccinated until they put out to sea to avoid giving generalized vaccinia to the kids at home. So there have been reports before where sailors then develop vaccinia and spread it while on shore leave. But this turned out to be the initial presentation of monkeypox right before it sort of exploded in Europe and the US. But those umbilicated lesions, very, very typical. And monkeypox has been around a long time. It's been around in Africa. Back in, what was it, maybe the 90s, early 2000s, we had a huge epidemic in the US related to prairie dogs that were being sold as house pets. And the viral inclusions that you see, that's courtesy of Eric Stratman. Um, from one of the Midwest was where there was that big outbreak, and you see the very characteristic intranuclear inclusions that you see with true pox viruses, whereas you just tend to see the cytoplasmic inclusions in parapox viruses. And then a patient from Africa, courtesy of Bob Riddell. Well, and then other viral diseases have been with us forever and continue to be a problem. Um, Herpetic lesions, just like pox and parapox, tend to be umbilicated. That grouping is what we refer to as a herpetiform grouping. That's why other things like herpes gestationis has nothing to do with infectious herpes. It's pemphigoid of pregnancy, but they tend to be grouped in a herpetiform grouping. Dermatitis herpetiformis is a gluten sensitivity where you get really itchy on your extremities. That also has a herpetiform grouping of lesions. That's why there's herpes in the name. But infectious herpes, we see herpetic whitlow in kids, we see oral lesions, we see progressive ulcerative lesions. This poor little girl was misdiagnosed and treated as impetigo. What you see when you look is the characteristic grouping, the umbilication, the pearly rolled border at the periphery. All of those are dead giveaways for herpetic infection. Many people with HSV2, which tends to be genital, are asymptomatic, so there's a lot of shedding and a lot of spread, which is why much of the population ends up with genital herpes as well. And then ophthalmic herpes, herpes gladiatorum, wrestlers, because they contort against one another's body. They get herpes in all sorts of unusual places, especially around the neck, that you'll see it. Um, all of these tend to respond to nowadays we tend to use Val acyclovir because it's better absorbed, but acyclovir is cheap and still available, as is famciclovir. And then for people with recurrent outbreaks, suppressive therapy, most of the time we'll do it with 500 milligrams per day of Val acyclovir. So that's the general regimen. And then if people have breakthrough recurrences, you can always double the dose. But the biggest impact of this is that it reduces the asymptomatic shedding. So among sexual partners and with kids at home, that can be important to people. Especially important because if women have it at the time of delivery, you get neonatal herpes. which has a 50% death rate untreated, and the remaining 50% have permanent neurologic disease. So every woman at the time of delivery should be inspected for evidence of herpetic infection. This poor child died. One of the takeaways is that dermatomal distribution is not always zoster. In anyone who's a neonate or immunosuppressed, dermatomal lesions are quite common with HSV rather than VZV. And then eczema herpeticum, very widespread. Usually people who have atopic dermatitis, they get a cold sore and it just keeps on spreading over the entire body. And you see the typical umbilications, looks a lot like smallpox at this point. You can see those lesions all over. And then in the immunosuppressed patients, you can get tongue fissuring and you can get grouped erosions. All very important to recognize. So where does the pathologist come in? Usually when it's not suspected. So these are immunosuppressed patients. The one where you at the bottom really should have been suspected with the scalloped border and the rolled pearly border. The other patient, immunosuppressed with widespread eroded lesions, often a biopsy is going to come into the lab. That's a little closer look at that rolled border that you have. More and more, we tend to have clinical images that come with us to the pathology lab. If they biopsy the center of this ulcer, you're going to see nothing but a fibrinous crust. The diagnosis is there in the clinical image. That scallop border, that rolled pearly border is diagnostic. And another immunosuppressed patient, erythrodermic from his systemic lymphoma. And again, you see that thread-like pearly rolled border that's so characteristic of the disease. One that remains very important is verruca zoster. If you see verruca zoster, it's usually undiagnosed HIV. And they present as widespread warty lesions. Histologically, it looks almost like keratoacanthoma. You have this very glassy pseudoepitheliomatous hyperplasia. But if you look in the follicles, you see the multinucleated cells with margination of chromatin at the periphery, and that is absolutely diagnostic. And when you see these warty lesions and you see those multinucleated cells, it's a patient whose HIV has not been diagnosed, and the patient has full-blown AIDS typically and is simply not being treated. Hand, foot, and mouth disease um, is another important viral illness. Um, Coxsackie A6 has emerged right now as the most predominant type, and it looks a lot like eczema herpeticum. So it's been called eczema coxsackium because you get these groupings of lesions that are then spread all over the body. And it becomes important to diagnose. What you're going to see is reticular degeneration rather than the ballooning degeneration that you get in other herpetic viruses. We'll get more into the derm path in a moment. Coxsackie A24 is an important cause of hemorrhagic conjunctivitis. There's a big outbreak in South Korea, but it comes in phases, and you get these characteristic presentations that are recognizable. And then human paraechovirus is an important spreading virus, most recently in Australia. Fever, rash, lethargy, sepsis, really sick people with viral meningitis, and it's often in infants with a high mortality. And these are some of those kids from Australia. What the clinician is just going to see a non-specific rash, exanthem, and often, biopsy becomes key to the diagnosis. Most viral illnesses are going to give you an interface dermatitis, often with spongiosis and some necrotic keratinocytes. And when you see that combination of patterns, you see spongiosis plus interface. It doesn't want to declare itself as one or the other. It's both spongiotic and interface. Think drug, viral syphilis, drug, viral syphilis. Don't forget drug, viral syphilis. When you see those mixed patterns of inflammation, especially vacuolar together with spongiosis. Rickettsial infections in travelers has been a big problem. African tick bite fever and Mediterranean spotted fever. They're going to be milder Rocky Mountain spotted fever-like illnesses. They begin with an S scar that's often biopsied, and you're just going to see tissue necrosis, basically. In the other areas, you're going to see a predominantly lymphoid vasculitis with vascular necrosis. Really unusual to see a lymphoid vasculitis that truly necroses vessel. And when you see that, you've got to think of rickettsia. It's, throughout the Caribbean. So people who visit the Caribbean. It's long been endemic. They were brought there from Africa many years ago. And, that's where we see most of the cases nowadays. Um, so this is one that is endemic in the US. It's especially in the southern states and into Southern California. Hotspot is South Texas. But anywhere where you have opossums, you can get rickettsial fevers, endemic typhus, and it'll present with these stellate or retiform purpuric lesions, often a really sick individual, especially if they've developed a UTI or a sinusitis and someone has given them a sulfa drug. They develop multi-organ failure very rapidly and end up in the ICU. So this is an ICU patient. Um, if you're in an endemic area anywhere in the southern US or warmer climates, and you have someone who recently had sulfa, and rather than looking like Stevens-Johnson, you get this retiform purpura and multi-organ failure, think of rickettsial disease. And what you're going to see histologically, again, is a lymphoid vasculitis with vascular necrosis. Measles is back in a big way. So there are a lot of anti-vaxxers in the US, very poor vaccination rates for measles. Measles is back in a big way. And, we've all seen the reports of recent deaths of kids in the United States from measles. It's going to be a morbilliform eruption, which simply means actually measles-like. So what some people refer to as a maculopapular rash, together with cough, coryza, conjunctivitis. So fever, cough, coryza, conjunctivitis equals a case report of measles, but the biopsy often comes in helpful. And what you see are these multinucleated giant cells. So this is one of my patients with measles. You've got the typical weepy red eyes, runny nose, cough. So cough, runny nose, conjunctivitis, fever, think measles. On biopsy, what you're going to see are these multinucleated giant cells within the epithelium, and there is an immunostain for it. So if you're thinking measles and the question comes up, CDC can help you. A lot of the state health departments can help you. And there is a simple immunostain that can be done to confirm the measles infection. Mumps is also back in a big way, especially on college campuses where you get horrible orchitis and often sterility in young males. And again, the key is going to be if it's biopsied, a mix of spongiotic and interface. So anytime you see that mix where it doesn't want to declare itself as purely spongiotic or purely interface, it's a mix of both. That's when you think of drug, viral, syphilis as your big three differential diagnosis. Zika virus was back in a big way, with microcephaly and fetal malformations as being a problem. Again, it's going to be a viral exanthem, and again, you're going to see that combination of spongiosis and interface dermatitis. There's another one similar to chikungunya and Zika that is now spreading. It's a big deal, and it's these fall into the broad category of hemorrhagic fever viruses. They all have morbilliform rash. Biopsies tend to come in, and for most of them, you're going to think viral when you see morbilliform rash. There's no new drug to account for it, and you see a mix of interface and spongiotic dermatitis. Lots of other emerging diseases, right? So hantavirus, you stop to get gas and you get a nice salad or sandwich as you're traveling through the Southwest or Southern California. If mice have been there and peed on the countertop at night, it's a great way to get hantavirus. Anaplasmosis is spreading among Ixodes ticks. Dengue has spread now into California from Texas and into all of the neighboring southern states. Remember, if you are a traveler and you get a second serotype of dengue, you get dengue hemorrhagic fever. And we had a patient walk into my clinic a few months ago. She and her husband, they're retired, they travel the world, they love to go to Asia, Africa, all sorts of exotic places, and the Caribbean. She came back from the Caribbean with retiform purpura and sky high IgM for dengue. She was lucky she survived her dengue hemorrhagic fever. The big thing there is brainstem hemorrhage that can happen. So you see retiform purpura in a world traveler. That's another classic presentation where you think of dengue hemorrhagic. And then the other one that's spreading is this severe fever with thrombocytopenia syndrome, spread all over China, a tick that was endemic to China, and now that tick has been identified in 24 US states along with the virus. So, we've got another severe fever with thrombocytopenia virus that was local and has become global again. So you got to watch for these things. And sometimes we get the ticks in the lab. This was a very common occurrence in New York where, everyone goes to the park or they, get out of the city and then they come back and they find a tick attached and they want to know, what do I have to worry about? It's not that hard to identify the major disease vectors. So the one on the far left is an Ixodes tick, black legs, inornate scutum, big oval tick. That's the one that carries Lyme disease and granulocytic ehrlichiosis. The one in the middle is the amblyomma tick, carries the Lone Star tick. You see that little white dot on the back. That's the one that carries Rocky Mountain spotted fever, ehrlichiosis. It's also a cause of tick paralysis. And in the southern states, it carries a form of Lyme disease. And then The last one, those are the Rocky Mountain spotted fever ticks. Those are the ones that have the highly ornate scutum on the back, very prominent festoons on their backside. Those are the dermacenter ticks. They also are the most important cause of tick paralysis, which has a 10% death rate, with the tick usually found in the scalp by the mortician. So how do you prevent disease? Well, permethrin is really easy to buy. You can buy it at Walmart, Target, anywhere, and spray it on your clothing. You don't want to do that if you're going to North Africa or the Middle East, where they have Congo Crimean hemorrhagic fever carried by these camel ticks, where the permethrin mimics the tick's sexual pheromone. And if you have the permethrin on you, you are suddenly very desirable, and the ticks are coming from everywhere to come and find you. So let's move on to the lab and to mycobacterial disease. Remains very, very common, especially non-tuberculous mycobacteria. 48% of all chlorinated city water supplies harbor rapid growing acid-fast bacteria, and abscesses are really common. You get a sterile abscess, think mycobacteria, unless it's around the anus where you're thinking anaerobes. Culture has been the gold standard, but it's really not that sensitive. And your best test is actually in the lab, in tissue, staining with auramine rhodamine. So we're going to get to that because mycobacterial disease remains highly prevalent. We see them as infections in the lab. You're thinking infection. If you are just using routine acid-fast stains, you are missing the majority of these infections. So this is from a study we did recently. Auramine rhodamine, you need a fluorescent microscope, but the organisms absolutely pop and fluoresce and are very easy to see, even if they're few in number. Um, in our study, only half of the ones that were positive on auramine rhodamine were detected by Phyte or Kinyon or other routine acid-fast stains. So if you're still doing the old-fashioned acid-fast stains, you are missing a lot of mycobacterial infections. And auramine rhodamine is an easy stain to adopt. All you need is a fluorescent microscope. Very easy to do. Um, we have gene probes, MALDI-TOF, all sorts of other things that can be done. But half of all mycobacterial infections are culture negative. And the gene probes are only positive once you've found the organism on culture. And again, remember, half are culture negative. So the diagnosis is made on auramine rhodamine staining the majority of the time. Even in leprosy. So on the left, you've got a traditional Phyte stain, and on the right, you've got auramine rhodamine. It is a lot easier to see on AR, and you can see every individual rod. And it is not hard. So if you want to take out your smartphone and snap a quick picture of this, or I'll send it to you, it is not a difficult stain at all to do. This is a patient who walked into our clinic recently with these lesions of psoriasis, not responding to biologics. And on biopsy, there is a lot of inflammation around the neurovascular bundle. And you see some granuloma around the neurovascular bundle. Well, that should always make you think of leprosy, right? Also these days, think of syphilis because we are seeing more and more syphilis, and especially tertiary syphilis showing up as granulomatous disease. Um, Next lecture that we do, the part 2 of this, we're going to go into syphilis in much more depth because a lot of cases are missed histologically, and you really have to be sensitive to the whole spectrum of disease. In this case, that is the fight stain. And, you see maybe something that's a little bit pink by the front of the arrow, but you look with auramine rhodamine, and there is no question that you've got a rod there, right? And this helped establish the diagnosis of leprosy in this patient. It was confirmed by PCR. There's an issue with PCR. It's much more sensitive in alcohol than in formalin. So if you're really looking for leprosy and you want the National Hansen's Disease Center to do PCR for you, put it in ethanol, not in formalin, and you get a much better yield. So this is a nerve, and you can see the acid-fast rods within the nerve. But there's a lot of clinical pathologic correlation. Anytime you have an insensate lesion, granulomas along neurovascular bundle, any kind of inflammation along neurovascular bundle, leprosy is still around, especially in the southern United States, and anywhere where you have an immigrant population. And so, we still see cases walking in. If you're sending for PCR, remember alcohol much better than formalin. And you can get National Hansen's Disease Program will do it for free. And then for these others, University of Washington is a good source. The processing is a multi-stage. Again, the big takeaway is you're going to get a lot of false negatives out of formalin. So you really want it in alcohol if you want a good yield. So 70% ethanol gives you by far your best yield. Um, Alcohol fixation, if you received it in formalin, get it out of the formalin and process into paraffin within 12 hours, and you're more likely to get a positive PCR. So what do you do when ethanol isn't readily available from the, lab grade ethanol, like happened during Hurricane Katrina? Well, we got everything in bottles like this, water bottles with ethanol, and the ethanol was a little brown because it was just from the liquor store, and it actually works just fine. So the winner, when we looked at sensitivity, was wild turkey, which is 101 proof. And your not only is your H&E beautiful, but IHC works just fine, and PCR works for any organism much better in ethanol. And if you can't get lab grade ethanol, you can go to the liquor store, and that works just fine. The National Hansen's Disease Center, they have a form that's, very user-friendly, easy to do. You can download it online, and it's all free. And there down at the bottom is the email. And another important thing is they will treat the patient for free if you identify the disease. There is a lot of leprosy that goes undiagnosed. So Maritza Lorenzo, she made the New York Times headlines, epidemic of leprosy in Central Florida. It wasn't an epidemic. It's the leprosy that's always been there in Central Florida. It's just that she started using auramine rhodamine and made the diagnosis. So these patients often have annular, psoriasiform, polycyclic lesions. If you see little fluorescent fragments, because the granulomas are trying to chew up the organism, you have AR positive little dots, not rods, that still counts, and that's real disease. So these are all reports that show that those little fragments with auramine rhodamine are absolutely real and are just partially digested organisms. Where you got to be careful is lipofuscin. So if you're in an eccrine gland or an apocrine gland, you've got lipofuscin, and that is going to fluoresce in a dot-like fashion. So you ignore those little dots that are in the glands, but you see dots in a granuloma, that's real. And then, the DNA assays, there are increasing ways to look with PCR at RNA, and the assays are getting better, but they all work better in alcohol rather than formalin. And then you just have to recognize it on H&E when you see it, because we still see lepromatous disease. Those are globi, those amphiphilic round collections of organisms within the granuloma. The granuloma loves the erector pili. So you see the sebaceous gland above, the erector pili coming in at a 45-degree angle. That is a great place for a tuberculous granuloma, or I'm sorry, a lepromatous granuloma. And then these are all globi. Again, those round amphiphilic collections. And there's a spectrum of disease, things that look like psoriasis, things that are polycyclic and look a bit like granuloma annulare or subacute cutaneous lupus. Anytime you have sausage-shaped granulomas along the neurovascular bundle, you got to think of leprosy. Leprosy in reaction is when patients get treated or they start to regain partial immunity and they start to get lymphoid infiltrates. The clue is you get onion skinning around vessels and nerves with a lymphoid infiltrate. That should make you think of leprosy. And if you've got onion skinning around not a vessel, but a nerve with neutrophils, that's ENL, erythema nodosum leprosum, which is usually someone who got pregnant. They didn't even know they had leprosy. They get pregnant and they show up with these skin lesions that are highly inflammatory. And that onion skinning around the nerve is a dead giveaway. So here we're on the face, and you have sheets of plasma cells, pretty common for the face. And then you've got these round collections, and they look a lot like globi. They're also, because of the plasma cells, there are lots of Russell bodies. This is rhinoscleroma. And rhinoscleroma, sorry, I'm getting over a bad chest cold. Rhinoscleroma is still present in much of the world, caused by a form of Klebsiella. It's going to give you plaque-like lesions on the nose. Looks a lot like Balmuthia infections, which is a horrible type of amoeba infection that you also see in warmer climates. So the histopath becomes really important to differentiate the two. Rickettsial infections, just remember that they're on the rise again. And don't forget someone with sulfa, with retiform purpura, that you want to think of rickettsial disease. And the measles outbreaks we talked about. Let's get back to the histopath. So the multinucleated epithelial cells, and nowadays we have a lot of IHC available for these organisms. You probably don't have it in your lab, but it's not hard to send out, and your state health department probably has it. And you can do everything from high-risk HPV types to measles virus, and you can stain with IHC, which pretty much any lab can do. You just send them the paraffin sections, right? Recently, an Ackerman grad, Sylvia, published on CD1A for leishmaniasis, and it works really well. Leishmania can be tough to see in tissue, but if you use CD1A as if you were looking for Langerhans cells, it really stains the leishmanial organisms and makes them really easy to see. Fungi can be difficult to see. PAS stain, it's still, you can have trouble, especially there's some fungi that just don't stain well with it. Especially Mucor doesn't stain well with traditional fungal stains. Mucor will stain with Gram stain. And then SOX10, which we think of as a melanocytic stain, is actually a great fungal stain when you're having trouble identifying fungi. Reflectance confocal microscopy is becoming more and more available, and it is now being used for a variety of infectious diseases. Way back when, Wilma Bergfeld, my mentor, said that she thought all sorts of neoplasms were caused by infections, and we just lacked the tools to identify them. Well, since then, she has been proved right with Merkel virus, with HHV8. Again and again, we're finding in everything from leiomyomas to Merkel cell carcinoma, we are finding viruses as the cause. So this is just a partial list of some of the things that, are viral associated neoplasms. And we now have molecular methods. So, PCR, it can be used to identify papillomaviruses, and it looks like a lot of our ordinary squamous cell carcinomas in skin are papillomavirus associated in sun-damaged skin. Okay, let's move on to some fun things to finish up. This I've got to thank Tony Hood for. She was kind enough to share these images. She presented it as a CPC, a 100-year-old man with a lesion on the arm, and here was the histopath. Well, histopath, you see reticular degeneration. That's going to make you think viral, but you also see cytoplasmic inclusion bodies, and you see some nuclear inclusion bodies. So now we're thinking pox virus. And there you see some of those inclusions. And this is her patient. So she was at Indiana University, and a janitor cleaning out a sub-basement found this huge jar, and you can see the severed human arm floating in the jar, and written on it is smallpox. So how does she know this is a 100-year-old man? Because the last epidemic of smallpox in the US was in Indianapolis, Indiana, 100 years ago, and this arm has been sitting in the basement since then. So she calls the CDC, describes what's sitting in front of her, and says, "What do I do?" And the person on the other end of the phone says, "Don't open it." So, of course, it got opened in a proper lab, and she was kind enough to share tissue with most of the derm and DermPath fellowship programs across the country so that they have teaching tissue of smallpox. You can see all the typical pox lesions there in the formalin. Okay, let's move on to some other, this one's kind of unfortunate. This is a 2-year-old who is actively being treated with an alkylating agent for Langerhans cell histiocytosis. This was the clinical image sent. It was sent as an LCH case to a national conference, and we were running the conference, and everyone who submitted cases gets a cut of everyone else's cases. So my derm path partner, Les LeBeau, was very OCD and wanted to be sure that every case was representative, that they all showed the nice Langerhans cells with the reniform nuclei, and then he cuts into the scabies mite. And this child turned out not to have LCH, but to have scabies, and now has a 20% lifetime risk of leukemia because of the treatment with the alkylating agent. That is a pretty tough discussion to have with the parents. So, this is scabies being treated as LCH. And there are, last time I checked, about 40 reports of kids treated for Langerhans cell histiocytosis who turned out just to have scabies. So make sure you're looking for the possibility of scabies mites. Crusted scabies is often misdiagnosed. Looks erythrodermic psoriasis with these big, very characteristic silver crusts. Histologically, you're going to see tunnels all through the crust, and within those tunnels, you're going to see all the popped ova that show up as scrolls and pigtails, and those are absolutely diagnostic of crusted scabies. So this is a patient who was sent down to me. The patient had had a cyst excised after returning from a trip to Central America. Didn't really find a cyst there, so closed, and the patient said there was infection, dehiscence, and so the surgeon was anesthetizing to clean it up when something like alien shoots up out of the wound. And so, of course, before the patient came to me, you already knew that this was going to be myiasis. Um, the maggot often is not identified histologically because it pulls away. It doesn't want to get cut. And so it pulls down into the tissue. So when you see a cavitary lesion with eosinophils, think of the possibility of myiasis. If you actually see the maggot, there's striated muscle, they're the pigmented CD, pretty easy to identify grossly. They are carried by flies. The flies will catch a mosquito, lay the eggs on the mosquito, and you just get a mosquito bite, and that can transfer it. This is another fun one that came into one of my friends, Rich Bernert. This is a patient who years ago was traveling in Mexico on a motorcycle, hit a rock, was thrown off the motorcycle, split his side open, and he remembers it was a marshy area, and farmers came to his aid, and they put something soft and squishy on the wound, and it felt a whole lot better. Well, years later now, he develops this cystic lesion in the wound, and when you look higher at this cyst, there is a secretory tegument, they're calcareous bodies, they're subtegumental cells, and there's a little bit of smooth muscle, just a wisp, between those subtegumental cells and the tegument, and this is an encysted cestode. So what happened all those years ago is they probably caught a frog or a fish and used the flesh as a poultice on the wound, and the worm simply migrates into his wound where it sets up housekeeping and insists, waiting very patiently for him to be eaten by a bear so that the progeny can germinate in the bear's gut and fulfill their life cycle. Well, for 50 years, he has stubbornly refused to be eaten by a bear, and so the cyst remained. And this is the lesion. It is a multiloculated cyst, and every one of those little daughter cysts when it's ingested, will germinate and become a worm, right? So there's the life cycle. And there are lots of these, different worms out there, and we'll see the human infections. So this particular one is Sparganum, which is a type of tapeworm. There you see it's um, a tapeworm-like organism. And then this is what they look like when they're excised. It is these weird multilocular cysts, a lot like a hydatid cyst in the liver. And then the organism identified by the very characteristic calcareous bodies that look like Schaumann bodies, together with smooth muscle and the subtegumental cells. And you're dealing with a worm. This one's very different. This one is a round worm. You can tell because it has striated muscle. It is gravid, which means that the human is the definitive host. And this is Onchocerca, right? So onchocerciasis, this is the patient, came in to see my friend Karen Warshaw. Patient was an African national and had this cystic lesion. And when the cyst was cut open, the worms, this is a mating ball of multiple male and female worms, and they came out spilling out, writhing and twisting. And Karen said it was the single coolest thing she has seen in her life, counting the birth of her son. I was not there the day the worms wiggled, but we did get lots of tissue. So what we're going to see more commonly is not the onchosarcoma, but microfilaria in tissue. And then when you see it, it's really important because there are lots of microfilaria out there, some of which don't cause blindness, and onchocerca, which definitely does cause blindness. And so when you see the microfilaria, if you've got this big caudal space and the paired oval nuclei adjacent to it, that's onchocerca. And that absolutely needs treatment with ivermectin or the patient's going to go blind. Well, let's talk about infections that mimic other dermatoses. Um, Congenital ichthyosis with T. rubrum, tinea corporis, mimicking erythema gyratum repens or other gyrate erythemas, which are things that derms will see. Erythroderma, the big one now is trichophyton indotineae. It is spreading like wildfire across the United States. The clinician is going to send it in as psoriasis, not responding to therapy. If you see a layered horn, basket weave on top of compact horn, look for fungus because this trichophyton indotineae is subtle and not subtle clinically, but subtle histologically, and it is spreading all over the US. So if you are not seeing it in the lab, it is probably seeing you in the lab. And, just be aware that when you see that layered horn, basket weave on top of compact, you're looking for tinea. Tattoo granulomas, big problem, and a lot of these are acid fast. And again, what you want is rhodamine stain. The clue clinically is it's in the gray tattoo. To get gray, you take India ink and you water it down, and the acid fast bacteria are in the water, right? So then there are all those conditions that mimic infection. So the other way around. So you can have things, sweet syndrome that mimics infection, Crohn's that mimics cellulitis, the autoinflammatory syndromes that look like erysipelas and cellulitis, bullous lymphedema that looks like immunobullous disease. And of course, your dermatologist can be your best friend in terms of helping you work your way through these. Calciphylaxis. More and more we're seeing non-uremic calciphylaxis, and it can look a lot like Fournier's gangrene. It doesn't respond to antibiotics. It does respond to thiosulfate. Look for the calcification in the tiny little vessels in the fat. And then we'll make in the last 5 minutes, a quick trip to the tropics where we have patients traveling and coming from. Here we see the septal, and you see the Russell bodies and the Miculate cells. So that's rhinoscleroma, right? Klebsiella rhinoscleromatis. And treatment as you would for other Klebsiella disease. This patient with a chronic ulcer and it's mycobacterial, again, auramine rhodamine is going to be your stain, but it's a Buruli ulcer. These were Africa, now they're all over South America, and now we're recognizing it in the southern United States. So mycobacterial diseases spread. They're often These get diagnosed as horrible pyoderma gangrenosum because no one's doing the auramine rhodamine stain. So when you see it in warm climates, with climate change, it is spreading. You gotta, just think mycobacterial, learn how to do an auramine rhodamine stain. It's not hard, and you will no longer miss these infections. Um, Smears and culture, but it's mainly smears. And then there is treatment for it once it's diagnosed. So these patients have, very disfiguring disease, and it is all lupus vulgaris, and TB is still around. It is still with us. It has not gone. So think TB when you think granulomatous disease. And again, your best stain, guess what, is auramine rhodamine. So how about this retired pathologist with this warty lesion? That is the prosector's wart, a classic manifestation of TB in the skin. And with that, we're going to sign off for today. And I think we have time for a question or two just in the last couple of minutes. Thank you very much. Next time, we're going to do a lot more bacterial diseases, spirochete diseases, big focus on syphilis because it's back in a big way.
Thank you so much, Dr. Elston, for covering all these various infectious diseases uh, and so many different entities that you have covered today. Um, Dr. Skapsky, so would you like to please have any questions that you might have for Dr. Elston?
Sure, that was incredible. Learned so much from that. Such amazing CPC cases there. One question I had, we talked about, PCR there with respect to mycobacteria. My question is, in your routine practice, Dr. Elston, do you typically now still send tissue cultures when you're suspecting infection in general, like a pan tissue culture, or are you now doing PCR instead?
So we have a universal PCR that we do. If we're thinking a routine bacterial organism or acid fast, we do still try to culture those because you can get sensitivities that way. The universal PCR is in widespread use, but again, it's not that great in formalin. If
Mhm.
you really want PCR of any sort, you want ethanol, not formalin, as your fixative. And PCR still has a sensitivity that's only about 60%. And so auramine rhodamine is how a lot of these mycobacterial infections are being diagnosed. And it's simple to do in the lab, very valuable. But when you're sending for universal PCR, ethanol rather than formalin is the take-home message.
Okay, and then is saline okay, or is ethanol pretty much it?
Saline until it can get into ethanol.
Okay, got it.
It's going to have to be fixed. Um, but ethanol is the way to do it. And just as I said, if laboratories have ethanol
Mm.
because it's used in routine tissue processing. But if you're in the clinic and you don't have a good source of ethanol, rubbing alcohol actually works. And a trip to the liquor store and buy a bottle of wild turkey works like a charm.
Love that trick. Thank you so much. Also, for those of us that don't have fluorescent scopes, is there a way to send out for the auramine rhodamine stain, like just for that?
Yeah, I mean, we get a lot of specimens sent to us for AR staining because we do it routinely. And lots of people who don't have a fluorescent microscope in their lab. It's easy to send. We're one source for it. There are, lots of other labs that could do it for you. A lot of university laboratories will be able to do auramine rhodamine. Again, it's a simple stain and just requires a fluorescent scope.
Okay, amazing. Thank you again. I'm not sure if you want to take any questions from the chat for now, or if you want to save those for next time.
There is one question from one of our, there are a few, but let me start with one of these. So the question is regarding measles, Dr. Elston. So, in states where departments of health have IHE for measles, who starts the process for getting the slides stained? Is it the
Um,
pathologists or the
Yeah,
treating?
it's the pathologist. You just call the health department and you find out, with measles being hot right now, either they have it or they'll facilitate getting it to CDC or, wherever it's going to go to stain it. The military does a lot of it. So Forest Glen Annex for Walter Reed still does a lot of the leishmanial work and other infectious work for the CDC. They're all part of the federal government, and any state lab can send to them and get these things done.
Right. Thank you. Dr. Skapsky, do you have anything, any questions to add?
No, nothing to add. Thank you.
Uh, yeah, I think there are a few questions, but probably like we are at the top of the hour. So maybe, we can, do you still have some time, Dr. Elston?
Yeah, I can take a few minutes. Again, next time we're going to focus on syphilis and fungi.
Right.
So, that's going to be the focus of the next lecture.
Right. Regarding leprosy, there is a question that since leprosy is a notifiable disease in the United States, so how can pathologists facilitate early reporting and outbreak prevention? And what barriers to timely diagnosis remain? If you have any advice for practicing pathologists in non-endemic zones, including the United States.
Yeah, so it's not just leprosy, but also tuberculosis. And the first thing is that testing like quantiferon gold that we depend on so much for TB testing is only 60% sensitive in an area with low disease prevalence, which is what the US is. So it's not that great a test, right? So often it's made as a pathologic diagnosis because it went on to biopsy because the serologic testing was false negative. Um, Again, just think of it when you see granulomatous disease. If you can't do auramine rhodamine, send the specimen to someone who can do auramine rhodamine for you. And then the reporting, your state health departments, they have the forms online, they'll take phone calls. They want to hear about these things when they're present, and they'll get you in touch with the people at CDC or National Hansen Center. Everyone, they make it really easy for you. All you have to do is make the first contact.
There is another question, Dr. Elston, that any practical advice for pathologists in non-endemic areas to differentiate on histology between leprosy versus cutaneous tuberculosis, when both are kind of can have granuloma?
Yeah, both are granulomatous, but cutaneous TB tends to love the surface. So you get pseudoepitheliomatous hyperplasia, a verrucous surface. The granulomas are up towards the skin surface, whereas leprosy tends to be deep. It tends to be usually perivascular, neurovascular bundles, erector pili. So you see deeper linear granulomas. You're thinking leprosy. You see verrucous surface and more superficial granulomas. You're thinking cutaneous TB, both of which are making a comeback in the US. Um, but the key is just to think of it and get the AR stain. And if there are fragments there, there are plenty of resources to help you. You know, with Maritza, again, she made New York Times headlines, huge epidemic of leprosy in Central Florida. She was just starting to do the stain and identifying disease that has always been there. Because if you've got armadillos, you got leprosy.
Right. Thank you. Dr. Skopsky, you have anything to add or any other questions or comments from you?
No, nothing.
All right. So maybe I think there is a couple, another question I saw on the chat box about leprosy again, that how do you advise that on histology or clinically to differentiate reactional states in leprosy from other dermatologic conditions that can mimic?
Yeah. So the key is often the onion skinning, telling you there's chronicity. So you've got onion skin fibrosis around the vessel or the nerve. That tells you it's been something that's been there a long time. Most of the other reactive simulants are going to be acute processes. This is a very chronic process. So you see onion skin fibrosis together with inflammation, you're thinking of mycobacterial disease.
One of our viewers is asking that is there any role of immunostain for tuberculosis or leprosy?
Yep. So there absolutely are immunostains. And interestingly, the same immunostain that works for acid fast works for fungi. So it was developed for acid fast organisms. It works for fungi as well. It is not for acid, it's great for fungi. It's honestly not that great for acid fast. Aramine rhodamine is a much more sensitive stain for acid fast.
Right. One last question. I think this is related to COVID and skin manifestations. In your practice and in your experience, what is your experience about seeing long COVID in patients, like delayed skin manifestations, and how they should be evaluated? Please, Dr. Elston.
So long COVID, you see, most of the manifestations are chronic fatigue, a lot of it related to myocarditis. It's fortunately a self-resolving myocarditis, but it's, one of the most feared complications of COVID, and people just have fatigue, no energy for years after. Most of the other things we see are just triggered autoimmune disease. There's been a lot published about every autoimmune disease from lupus to pemphigus being triggered by COVID vaccine, and that absolutely can happen, but they are 10 times more likely to be triggered by COVID itself. So I'll take my chances with a vaccine because you're more likely to get chronic autoimmune disease from getting COVID than from getting the vaccine. But the skin things we see are just the whole array of autoimmune dermatologic conditions that can be triggered by either natural COVID most commonly or by vaccination.
Does that mean that the histology is not very specific that will mean or indicate COVID at all?
Well, correct. The the histology is specific to the autoinflammatory or to the autoimmune disease, but doesn't tell you in any way at all whether it was COVID related or not.
Right. Thank you. Thank you so much, Dr. Elston. I think these are all the questions that we found online on YouTube and Facebook. And thank you so much for this comprehensive review of so many different infectious diseases. And we hope to have you again for the second part, as you will be covering the other aspects of infectious dermatopathology. And I think that's coming up in July. And for our viewers, and Dr. Elston, you would be happy to know that we have a lot of viewers who joined from different parts of the world. And I could keep track that our colleagues joined from Peru, Somalia, India, United States, of course. There are many who joined from here, Poland, UK, just to name a few. And thanks to our viewers. And if you like our lectures, please don't forget to follow us on social media platforms like Facebook, YouTube, Instagram, as well as X. And we will continue with our lectures, and our next talk is coming up. That is, we will switch to hematopathology. We are also having a hematopathology lecture series, and that's on 28th of May. And our speaker is Dr. Nidhi Agarwal. She is Associate Professor at University of Pittsburgh, and she is going to talk on hematopathology in the molecular era. So hope to see you at that time. And thank you again. Thank you both, Dr. Skapsky and Dr. Elston. And special thanks to Dr. Skapsky for helping us in organizing this series. Thank you so much. And thank you. Thank you both.
Thank you
Okay,
so much.
bye-bye.
Take care. Bye-bye.
Bye.